Thank you for coming to Grand Rounds. My name is Stephen Gray. I'm I'm one of the transplant surgeons at University of Maryland, the University of Maryland Medical Center in Baltimore. We're going to talk today about liver transplant for malignant disease. We'll touch on all malignant diseases that affect the liver. Please feel free to ask questions as we go along, and I'll get started. So I have no disclosures. So the objectives of this talk are to understand the role of transplantation for hepatocellular carcinoma, understand the role of transplantation for cholangiocarcinoma, and understand the possible expansion or the future directions for transplant for all types of malignant diseases. So we'll talk about the history. So the history of liver transplant. Liver transplant is still relatively new. The first successful liver transplant was in 1967 by Tom Starzl. It started in pediatrics. You see, this is Dr. Starzl here. He subsequently moved on to University of Pittsburgh, where he's become very famous, and developed transplant, and developed liver transplant and successful liver transplant techniques. Hepatocellular carcinoma is the fourth leading cause of cancer-related deaths in the United States. It's the fastest growing cause of cancer death in the U.S. And between 1975 and 2009, the incidence within the U.S. increased threefold. So it's one of the few cancers that's still growing and is increasing. Increasingly, though, due to imaging, it's being diagnosed at early stage. As you know, like somebody gets, like here, you guys have a trauma center. Somebody comes in and they get the trauma, and you find the trauma incidentalloma on the scan, and sometimes that is liver disease. Hepatocellular carcinoma, the cirrhosis is still the major risk factor. It doesn't matter how you got the cirrhosis, but it's still a major risk factor. Patients typically die of liver failure, but not from metastatic disease from the hepatocellular carcinoma. Because usually, again, the fact how you have cirrhosis increases your likelihood of developing hepatocellular carcinoma, and that is the cirrhosis is related to end-stage liver disease, and therefore the liver failure is actually what kills you, not the progression of the disease. Early on, in the early 1990s, primary liver cancer was a contraindication to transplantation. In the Italian group in Milan, that's where this Milan criteria came from, they were able to show excellent survival in patients with cirrhosis with stage 1 and stage 2 tumors. Because at the time, the option was either transplant, which wasn't an option, or they would just progress and die. These weren't people who were, because of the cirrhosis, that they could undergo a resection safely and survive. The group in Barcelona subsequently came up with the BCLC staging and treatment schedule, and this is kind of what most places what we kind of use now. And you can see here the big change occurs between right here, where you kind of have this cutoff, where you start doing local regional therapies that are non-curative versus these other things here, which are curative. So around 30% of patients can undergo a curative therapy, whether it's resection, liver transplantation. The majority of patients are either treated symptomatically because they presented so late and they're terminal, with the 1-year survival following the diagnosis of cancer of around 10 to 20%, versus the people here who undergo local regional therapies, so whether it be chemoembolization, microwave ablation, things like that, who end up with a 20 to 40% 3-year survival. So of all things, hepatocellular carcinoma is a bad actor, but it's not the worst. So here, this was again back from the Milan group. They were showing the survival or recurrence-free survival after transplant. And so you could see here, even at around 3 years out or 36 months, you still have greater than 80% survival without a recurrence following transplant. And that's the difference between undergoing transplant and undergoing resection, where almost 50% of the people you resect with hepatocellular carcinoma are going to recur. So liver transplantation is an accepted treatment modality for hepatocellular carcinoma. The Milan criteria, which was established in 1996, or published in 1996, kind of formed the basis, or the early basis for what was acceptable for liver transplantation. And so what they found was a single lesion up to 5 centimeters. That was a good patient to transplant. 3 lesions or fewer, so multiple lesions up to a total of 3 centimeters each one, and no major vascular invasion, so no malignant portal vein thrombosis or malignant extension of the tumor into named vascular structures. And utilizing this criteria, they were able to demonstrate 75% 4-year survival, recurrence-free survival of approximately 83% at 3 years, which we just showed. But the question now is that too restrictive? Because we all know that this criteria, these numbers, although they were published and they have been found to be scientifically sound, they're a marker for tumor biology. They're a surrogate for tumor biology, and that's what we're really trying to get. So the question is this too conservative? Or is this too restrictive? Are there patients we can expand this option to? And then how does live donor? How does that fit into this? Because what we have to remember is transplantation organs for transplant are a constrained resource, so there's a limit, right? Because we don't have donors. We don't have donors on shelves and organs just sitting around. We are trying to use organs from every potential donor that you possibly could. And so if I say yes to you, that means I'm saying no to somebody else. And still knowing that the outcome with a transplant, even with advanced disease, is better than any other therapy we have, but I'm taking that organ from you when it could be potentially used someplace else. So what about live donor? What if it's your child or your parent who's willing to give you an organ, or your spouse? How does that change that? And then the other question is how should tumor biology guide what we're trying, who you transplant? Because that's what this really all is again, is a surrogate for tumor biology. So here we have a slide showing a typical HCC on from MRI, and you can see the tumor here. It's 4.1 centimeters. It's really this person is obviously has liver disease, because you can see the spleen is quite large, and you can almost pick up some little varices here, and then the liver started to lose its contour and started to shrink. So this is not somebody who's going to be able to tolerate a resection well, which would be the only other curative option for them. So the University of California, San Francisco, they decided that again, one of the earlier groups that published that these other criteria are too restrictive. So they came up with this criteria now with 1 lesion less to or equal to 6.5 centimeters, or 2 to 3 lesions that are each less than 4.5 centimeters in tumor diameter. And if you add them all up, the total tumor burden is less than 8 centimeters. And they found with this that they found a 75% 5-year survival following transplant, which again, when compared with the other therapeutic options, is more than acceptable. The group in Seoul, where in Korea live donor is in lots of the world, live donor is the more common form of donation. They started looking at markers of tumor biology, such as the alpha-fetoprotein or the PIVK 2 level and PET positivity. They found these things were all. They use all of these in their criteria. They also looked at, they also found, in their group they found these things made patients high risk. So the alpha-fetoprotein greater than 100, PIVK greater than 100, or equal to 100, and a positive PET. Those are high risk patients who would be high risk for transplant. And in their population losing live donors, they stated that their only absolute contraindication is extrahepatic disease. Again, though, this is a slightly different patient population than what we have here. I actually spent 3 weeks over with this group a couple years ago, and it's a skinnier patient population, one. But then the other part is a lot of their disease is hepatitis based, Hep B and/or Hep C based disease, which is different because a lot of times in hepatitis B you get very large tumors, but not in a cirrhotic patient. So there's a little bit of a difference. They found that recurrence, which is when the patients, even with the high-risk ones, when they recurred, they would offer them resection in the transplanted organ. They also found that mTOR-based immunosuppression delayed progression. So there are two kinds of mainstays of immunosuppression. You have the antimetabolites like mycophenolate mofetil. You have Then you have the calcineurin inhibitors like tacrolimus, and then you have mTOR inhibitors like sirolimus. And the mTOR inhibitors are nice because most of these tumors also signal through an mTOR pathway. So if you treat them with the mTOR inhibitor, the thought is that you decrease recurrence. And then finally, if they weren't a candidate for surgical resection, sorafenib, which is a multi-tyrosine kinase and angiogenesis inhibitor, was started. And sorafenib, most of the time in the U.S., is used as like, if somebody's not a candidate for anything else for their hepatocellular carcinoma, you'll start them on sorafenib. So they found, this is from the Korean group, they found that here, looking at the probability of overall survival versus duration and follow-up months, the patients, even their patients who were outside of Milan had a 65% overall survival and almost 60% disease-free survival. Disease-free survival. So again, this is, when you're talking about a cancer with a survival that you measure in months to years, getting somebody out to 5 years is probably an acceptable outcome. And they put this statement out that living donor transplant should be considered in patients with advanced hepatocellular carcinoma if there are no other effective treatment options and if the patient is expected to benefit from liver transplantation. Hepatocellular carcinoma patients with favorable tumor biology should not be excluded from liver transplant. Patients with favorable, particularly live donor transplant, solely because they're beyond Milan criteria. HCC patients with favorable tumor biology should not be excluded should not be excluded just because of beyond criteria. And the combination of surgical resection, mTOR inhibitor, and sorafenib can enhance long-term survival and even after post-transplant HCC recurrence. And they were actively expanding their indication for live donor transplants with far advanced HCC in selected situations. So that's HCC, and that's probably not HCC is not a controversial option for transplantation. Now we'll move on to cholangiocarcinoma, and this is the second most common primary hepatobiliary malignancy within the United States. It's 3% of all GI malignancies, so it's still relatively rare, and it's only 10% of primary hepatobiliary malignancies. It still is associated with 50 to 70% mortality at 12 months. In a surgical resection, you get 27 to 44%. So it's a very wide these were not, it wasn't a homogeneous patient population. 5-year survival. And this here shows you a cholangiocarcinoma right here as it grows along the bile ducts. And the thing with cholangio is oftentimes it doesn't present until very late, until somebody turns yellow. And that's one of the problems. It's usually very advanced at the time of presentation. So, but for selected patients, transplant is an option. And I'm sure that some of you guys are residents from Georgetown. Is that correct? And some of you guys have trained other places in the DC area. Each transplant center has a cholangio protocol. Because these are oftentimes younger patients, and because there's no other real good treatment options for them. So cholangiocarcinoma, things that predispose you to it are primary sclerosing cholangitis, a history of ulcerative colitis, patients who have choledochal cysts, hepatic parasites, stones on the bile duct, being hepatitis C positive, and it can be defined as intrahepatic, perihilar, or distal. So this slide here shows kind of where it can occur. So the ones that are transplantable are generally the ones here that are the perihilar. We don't really transplant for intrahepatic cholangio because of poor outcomes. And then distal cholangio oftentimes is something that you're treating with a Whipple because it involves the head of the pancreas. So it's oftentimes unresectable, and what determines resectability is invasion into the artery as well as into the main portal vein. And because of this invasion, it can become unresectable. So in order for it to be resectable, it would have to involve the lobe of the liver with invasion of the contralateral, with invasion of the the same side branch of the portal vein and the hepatic artery. So if you have, let's say, tumor that's going to the right side, but invasion of the left hepatic artery and the left portal vein, that's somebody who's not resectable. And that's somebody who, with a small tumor, who we would love to see and to talk about for potentially undergoing the transplant protocol. So the data for transplanting patients with cholangiocarcinoma came out in kind of in 2012 was the start of it. So it was a meta-analysis of 605 patients undergoing liver transplant for cholangiocarcinoma. The pooled 1-year overall survival of 75%, 3-year overall survival of 42%, and a 5-year overall survival of 39%. Patients who were transplanted after neoadjuvant therapy, so treating them before resection, before their transplant, was greater than 65%. So patients who are safe to undergo transplant for cholangiocarcinoma would be patients with unresectable cholangiocarcinoma, a diagnosis that's based upon radiologically malignant stricture, so we don't necessarily even have to have tissue, but we all would have to agree that it's radiologically malignant, a CA19-9 of greater than 100, and a positive brush cytology. And they would also have to physiologically be a candidate for transplant. Exclusions for transplant for cholangio would be extrahepatic disease, or if the patient had an operative biopsy or attempted resection. Percutaneous biopsies, according to most protocols, would knock patients out from being excluded, uncontrolled infections, or intrahepatic cholangiocarcinoma. So it's really important from this standpoint that these patients are referred to a transplant, to us at University of Maryland or to a transplant center early on in their diagnosis to help guide things, and so things don't happen to them that would knock them out for candidacy. I mean, and I speak to this not only as a physician who provides care for this, but also as a family member of somebody who was recently diagnosed with cholangio. So my dad, back in March, was at Maryland. He had a gallbladder out, went on a cruise back in October, came back and turned yellow. He's also a physician, so he'd been self-medding himself on the cruise for diarrhea or something, and he read that a common side effect was jaundice. I was like, Dad, that's not the case. You either have a stricture from your cholecystectomy or you have something bad. So he ended up getting scanned, and he's not a candidate for a resection or for transplant, so he's undergoing chemotherapy now, but it's the same type of thing. The key was for me to get him to a transplant center. I got him to Henry Ford Hospital in Detroit, and they're kind of doing the same things that we would all do. So these are all kind of very much a standardized protocol because you want patients to be seen someplace that could potentially do resection as well as could do a transplant. So the protocol would be neoadjuvant chemoradiation. So it's external beam radiation, and then standard chemotherapy, which is the 5-FU and gemcitabine, and then we'll either do more radiation therapy at 2 to 3 weeks following completion of the external beam radiation, and then more chemo until the time of transplant. And then at the time of there used to be a lot of the older protocols, if you read any of this, they would involve a staging laparoscopy or staging laparotomy. We've gotten away from that, and we just stick with scans and EUSs in order to see if they have progressed. Now, this is one of the few times in which we'll go into a transplant, start a transplant, maybe sample some nodes, and actually have to back out because of tumor progression. So again, like we said, there's exploratory laparoscopy and endoscopic ultrasounds. The endoscopic ultrasound has definitely replaced the exploratory laparoscopy. And then our protocol, this is actually copied straight from our protocol, is that a backup patient is called into the hospital at the same time as the primary if you're doing a deceased donor transplant for this person, in case the recipient is found to be not transplantable, because the last thing we want to do is waste an organ. All right, so now we're going to shift to neuroendocrine liver metastasis. So this is one of the few metastatic indications for transplant. So the incidence is less than 5 per 100,000. So these neuroendocrine tumors, they need to have a low grade mitotic index. And you can tell you grade these tumors based upon their mitotic index, G1, G2, and then high grade. Depending on the mitotic index. This is a slide showing neuroendocrine tumors throughout a liver. And then treatment would be standard treatment would be anti-hormonal therapy to get them under control, to control their flushing or their other symptoms. Interferon and chemotherapy treatment, regional ablation for those tumors if they're enough that we could just ablate them and to take care of them that way. And then finally surgery. And so liver transplant for neuroendocrine tumors gives you a 5-year overall survival of between 49 and 52%. So these are equivalent to HCC. And so for malignant indications for transplant, the HCC is kind of the gold standard as far as outcomes. So if the outcomes are equivalent to HCC outcomes, then it's something that we would consider. Now, hepatoblastomas are the most common primary hepatic malignancy in children. We see this 1 to 2 per million. And what we'd say with this is most of the time they have protocols now, the chemotherapy and radiation protocols now that the kids would go through. But if it's not resectable after the second round of chemo, then that's when they should be referred for transplant. And liver transplant should be offered to all patients with unresectable hepatoblastoma. And even this is one of the few tumors that if it does have mets, especially to the lungs, if you can resect the mets beforehand, we would still offer that child transplant. And so this is a picture of a CT scan showing an unresectable hepatoblastoma in the right lobe of the liver. And it's unresectable because how close it is here to the its involvement of the right vein, and then the amount of residual liver that would be left. They wouldn't have enough residual liver to not be a liver cripple afterwards. More obscure indications for transplant would be hepatic epithelial hemangioendothelioma. It's a high-grade malignant soft tissue tumor. It's very rare at 1 per million. Clinically, they present all different ways, and so it's very hard to come up with what they are. Some are very indolent, whereas others can be very aggressive. So liver transplant is for unresectable disease with or without extrahepatic disease, and for the diffuse pattern within the liver, one that's not resectable. Tumor size greater than 10 centimeters. Greater than 10 nodules in the liver that you couldn't go through and just resect each one of those 10 nodules, or greater than 4 segments of liver involved. The overall survival with this is very good, with 83% even in the 83% 5-year overall survival, even in the presence of extrahepatic liver disease, which is very good. In the 5-year disease-free survival between 46 and 82%. And then finally, we'll talk about colorectal mets. As we know, we oftentimes see patients with colorectal mets from the colon cancer. It's the most common spot that colorectal cancer metastasizes to. And almost a little bit over a third of patients with metastatic colorectal cancer have metastasis only to the liver. Currently, it is a contraindication to transplant. And this is for a number of reasons, like we've talked about, allocation justice. We already have a shortage of organs. We really don't need another indication for transplant. And the high rate of recurrence after transplant. And again, those are things that that may change if you were talking about doing a potential live donor, where you're not taking an organ out of the pool that's available to all the people who are waiting on the list. This is a slide here showing what a colorectal met looks like in the liver. Remember, it's a dark tumor, oftentimes in the right lobe, but that's a large colorectal met in the liver. Of course, somebody someplace has done transplant for it. And so in Norway, they've actually done this successfully. So I found this out when I was previously, before my prior job before I moved to the University of Maryland, I was on faculty at the University of Alabama in Birmingham. And this young woman had come in to see us in clinic, and she had colorectal mets. And I was like, I'm going through my whole spiel about, I'm sorry about your cancer. This is what you have. We can't transplant you. This isn't something that's indicated. I should have known by the fact that she brought her brother in with her that he had data to go against this. He was some researcher from on the East Coast and was telling me about transplant in Norway. And I was like, okay. Made some excuse, faked a page, went out in the hallway, and got on PubMed real quick because you can't look you can look bad, but you can't look terrible in front of patients. And he was right, and it was an indication. And and I think that in the area of the world where you have excess organs, this is something that's obviously is something that you could try to do. And so in Norway, they published this with 21 patients who were diagnosed with unresectable colorectal liver metastasis. They reported a 1-year overall survival of 95%. A 3-year overall survival of 68%, and a 5-year overall survival of 60%, with the following caveats: that the maximum tumor diameter was less than 5.5 centimeters, the time from the colorectal cancer surgery was greater than 2 years, the CEA level was less than 80, and they had stable disease or partial response after chemotherapy. And this was actually published in the Annals of Surgery. So there's obviously, you can't argue with those results, but what you can't argue with is how we still don't have enough organs, and so in the U.S. that's still a contraindication. Hopefully in the future, as we expand the organ pool via either increased donation rates or xenotransplantation, which is definitely an area of focus at a number of institutions, or through live donor transplantation, we can expand to this, because I think this is potentially an area that we should be looking at. And additionally, though, hopefully through increased surveillance for colorectal cancer early, we don't see as many patients presenting late with disease an advanced disease that will lead to metastasis. Thank you very much for coming. I appreciate the opportunity. Sorry to give you guys back 20 minutes of your morning, but I'm sure that you can find something else to do with it. If you have any questions, I'm more than happy to answer questions. As far as transplant in general or liver disease, we're very interested in transplant. I'm also very interested in hepatobiliary surgery, and happy to talk about any of those things. Yes, the question. So the live donor, we want to leave the live donor with between 30 and 40% of their remnant liver, and they would do just fine with that. We predominantly take the right lobe of the liver, so we end up taking a little bit over 40. We end up taking around 50% of the liver, but we always want to fudge and leave enough liver for the donor. Why? Just because when you take the right lobe's around 60% of the liver, and so that's just that, and it's all based upon inflow and outflow to the liver. Mm-hmm. Any other questions? Yes, sir.
When you do the baby liver cancers,
yes,
you're going to really only need a really small piece of liver. How do you justify taking a whole liver and using just a piece?
Well, generally, so. I do pediatric transplant, so we generally, size is a big deal with the kids. So generally, if you're going to use a whole liver, using a whole liver from a same size child. If you're using a piece of a liver, we generally try our best to split with another center and take just the left lateral segment for the child and leave the remainder of the liver for somebody to use for another adult. And I've been on both sides of that operation. I've used the remainder of the right lobe in an adult, and I've also taken the left lateral segment and put it in a child. So the idea is to try and get 2 livers out of that one donor.
Yeah, but just to follow up on that, if you have a liver that you're going to be used for transplanting, and you know that the liver grows so well, why don't you section one donor liver to 3 or 4 or 5?
Well, so
go ahead and do that?
Well, I think a lot of it's the logistics of it. You have to kind of have the perfect donor in order to split a liver and to use it into 2 adults. At my prior institution, we've done that. We did that twice. We split a liver into 2 adults. Currently, with the allocation system, it kind of disadvantages that because one person's going to get a normal artery and one person's going to get a short artery. And you're taking a lot of risk, and what we didn't talk about here is how regulated transplant is. And so, like, if your outcomes are less than a certain level, you get into trouble. Now, less than around 90% 1-year survival, you start getting into trouble. And you using that small segment, the splitting the liver increases the likelihood of you having technical difficulties. So it's something that you can do, but it's something that's probably, unless for some reason the center that's getting the organ is the same, the center that's getting both is taking the risk. A lot of people will say no, they won't use that other segment of the liver. They will waste it. I disagree with that. I think that, and most of the people in the pediatric community would say that any young donor to split off that left lateral segment and use it for a kid is perfectly safe, and I agree with that because you're really not increasing the risk. It's when you start talking about splitting for 2 adults where one's getting the right lobe and one's getting the left lobe, that's when you start running into trouble. And a lot of times even anatomically you can't, there's livers that are not suitable anatomically, and then a lot also depends on the donor hospital where you're at, is their ability to have the technology even to get a good 3-phase CT scan in order to be able to make that decision. Uh-huh. Any other questions? All right. Well, thank you very much.